I'm going to talk about our experience with the new Aquilion One Insight, which we've had for more than a year now. Not Health Canada approved yet, but I promise we haven't been killing anyone over the past year. So just to say that anything you don't like that I say, blame me. Don't blame Jens or Narinder. It's my own personal opinion. So I tried to, when I was thinking about this talk, I tried to break it down to what do I really want when I've got when I'm looking at a CT scanner, what I want from it. And then I thought, well, actually, it's not really about what I want, is it? It's more about what I need, and particularly what the patient needs. So what I need and what we need is easy scanning workflow with high patient throughput. And we all kind of say that, but we really do need that. We need good images, high resolution images with no noise and artifacts. We need low radiation dose, and we need to be able to scan everyone who walks through the door. And for us, certainly in a big general hospital like us, we want a scanner that just kind of does it, that just works without me having to sell one of my kidneys to buy it. So I'm going to talk about the first bit of the talk is about workflow, because it's quite different, this new scanner, in terms of workflow to compare with previous generation scanners. So in England, and as you can see there down the bottom there, also in Canada, we have relatively few CT scanners per population. You see the US is way up there, but also surprisingly, Iceland and Australia are actually way up there. But so we don't have that many CT scanners. So how do we increase the availability of CT? Because we can't just keep buying scanners because the government won't fund it. So we need faster throughput to make the best of what we have. And even in rich countries, such as the USA, Canada, non-Brexit Europe, I don't include England because I'm not sure we're a very rich country anymore since we made that incredibly stupid decision. There is a need to increase throughput to offset the poor reimbursement rates. So whatever system we're in, we need to do it faster, better, and cheaper. So we need the scanning to be easier and more reproducible, and we need image quality to be always good every time and at low dose. So even with the low number of CT scanners we've got, you think we'd be able to staff them easily, but we can't. And just as in every country in the world, we can't get enough radiographers, enough skilled people to run these scanners, to scan them. And we've got huge numbers of unfilled posts. And this is a problem across the whole world at the moment. Academic, if you're at the Mayo, Mass General, Bournemouth Hospital, UHN, London, they're all got the same issues. So there's a huge worldwide shortage of radiographers, the techs, and we do everything we can, which is incremental to increase training. I do a lot of stuff on cardiac CT. We run training courses, and all of that helps, and it's all incremental. But CT is absolutely exploding at the moment. So it's completely outpacing, the demand for CT is completely outpacing the supply of radiographers. So we need technology, and the techs need technology to help them out here to make the scanning process faster and easier. And particularly when you're in a kind of stressed environment and someone's saying, can you fit this extra patient and you need some help? And this inevitably means, and this is disruptive, it means more scanner automation. So this is the new Canon Instincts interface. It looks quite different from the previous interfaces that you've all seen before, and all of the platforms look like this going forward. So it's I much prefer it. It's a much more logical laid out system. This just shows what the new Instincts system does. Basically, you say, I want to do a chest CT. You do a 3D scanogram. That image on the right is a silver filtered 3D scanogram. It's actually a CT scan, but it's at the same dose as a normal scanogram. And using that 3D information, the scanner auto plans. So it's now able to plan the chest. This is what it's doing in real time. And then it scans the patient. And this is super, super robust. We helped develop this, actually. So we've had this quite a while, actually, because we had it for a year or so before it was a product. And it's, obviously we had a few problems in the early days. It was detecting all sorts of strange things, but it's actually super robust and super reliable now. And for cardiac, which is quite a difficult organ, it does this 3D scanogram with the silver filtered, and then it segments out the heart and then does a very sophisticated, it basically puts the region of interest field of view around the heart, and that's reliable too, and that really improves our throughput and our reliability. And this is just to show that I'm not making it up. This is the most difficult bit. This is cardiac auto planning. You'll see on the right, that's the 3D scanogram going, the silver filtered one. It's a CT scan essentially. And then the scanner's thinking about it a bit. It's doing a bit of math, and then or is it math over here? And then it basically plans the heart. You'll see the region of interest coming up there on the heart. So it works. You also, because you do a silver filtered 3D scanogram of the whole chest, you also get a free view of the whole chest, and you pick up lots of things. This is Patrick's going to talk about this a bit later. This is an ultra low dose scanogram, about the same dose as a chest X-ray, and you can see the 3 centimeter left upper lobe cancer that you cannot see on the chest X-ray done on the same day. So you pick up all sorts of things, which is useful. So the automated workflow is much, much faster than it was before. Rather than having loads of steps, you've got kind of one step, and the computer is taking out the heavy lifting, and it's taking out the not so interesting bits of the scanning process. I mean, people like doing the kind of planning and stuff, but interestingly, our radiographers hate the old scanner now, where it doesn't auto plan, and these are the people that said that they would hate it. So it is interesting. But this is disruptive. It's a new way of doing things. It challenges existing practices, and none of us like change. We're going to say I like doing it like I did it last week. So this is our scanner. This was when it was first put in more than a year ago. So it's got this new Instincts interface, which is the automated interface. It's got 16 times 0.5 detectors, like all Aquilion ones I've always had. So that's the bit that's the same, but pretty much everything else is different. It's 0.24 second rotation. It pulls over 75 Gs, I'm reliably informed, which is amazing. It's got a new Canon tube. It's got 1400 MA max tube. It's huge. I mean, it's huge output. It's actually a very small tube. And it's got these deep learning reconstructions, which have been really perfected for this system, which you're going to hear a lot about later. So this Instincts interface helps the workflow. It makes it much faster for us, much more reliable, much easier for training. And we've got a powerful tube, which means we can scan all patient sizes. So how do we improve image quality, and how do we reduce radiation dose? Well, the detector that's in this system is actually quite a lot more efficient than the ones that have gone before. So we make a lot better use of the photons that we've got. But can we do anything with resolution? We've got 0.5 millimeter detectors. Can we make the resolution better? Now, this is PEAK, which you'll hear more about later. PEAK basically is the system has learnt from an ultra high resolution system, a precision with 0.25 millimeter detectors, and that's its ground truth. And basically, it's learnt to synthesize the images from that. So it's not magic, but it's able to get down to the limiting resolution of the 0.5 millimeter detectors, which we were quite a way away from, and most vendors are quite a way away from. So we're able to use the whole detector resolution that we couldn't before. So how does that help us clinically? So we can really use those 0.5 detectors. We've got peak 1024, so we've got much more resolution in the XY plane as well. We've got much smaller voxels is the bottom line, and it also is very good at cleaning up image noise and improving our low contrast resolution. And this is all deep learning. So how has it changed our practice? That's the bit that matters. So the tube is powerful enough and the detectors are efficient enough to scan almost all cardiac patients. I'm starting off with cardiac because that's what I do. But we can scan large or small and with pretty much any heart rate or rhythm. And that I probably couldn't have said that before. And the 0.24 really helps. So this is not just the best case we've ever had. This is a fairly typical case. This is a tough patient. This is quite large. They've got atrial fibrillation, 155 beats a minute. This is an end systolic reconstruction. And you get a very nice view of the dominant circumflex there with the calcified plaque. I mean, this is better than our best image used to be. And this is in AF at a very high heart rate. These are the kind of images you get with peak 1024. And I promise you, this is an energy integrating detector image. This is not photon counting. But, I think this looks pretty good. This makes my life much easier when I'm reporting. Those bits of calcium, the amount of blooming from that calcium is dramatically less because the resolution is much better. So I can see that patient's got a lot of plaque, so they're high risk. But they haven't got any flow-limiting stenosis, so they don't need a cath. And our cath rate is dropped to pretty much zero since we had this kind of technology. They have one diagnostic list every month, whereas they used to have one every day. So this is the effect on calcium. This is the older technology in 2012, which was good at the time. This is hybrid iterative reconstruction from a vision. That's a sort of systems that a lot of the vendors have. And this is our new system from 2024. You can see it's just like you've got some new glasses. The whole thing has been sharpened up. You can cope with patients that we couldn't have even coped with before. This is someone with a calcified left main aneurysm from Kawasaki's disease, and then they put a stent in, and they wanted to make sure it was correctly deployed. And you can see all that. The stent is calcified, but you can still see it. The stent's patent, and the aneurysm's there. And we couldn't have coped with this before. This is just the effect of the algorithm. This is an image on the left from the Insight with a filter back projection. You can see something there, maybe in the mid right coronary. And then on the peak 1024, you can see that non-calcified plaque. You can also see another non-calcified plaque more proximally. I mean, you do see more plaque, but that's because you're seeing the truth. And, well, Patrick will talk about truth and AI later, but we think we're seeing the truth anyway. This is the hybrid iterative reconstruction against peak and against peak 1024. So the image on the left from a vision shows a bit of plaque. This is a little bit later, but only about 18 months later. And you can see that calcified plaque proximally in the LAD. You can just see it much, much better. It's much higher resolution, and the peak 1024 is even better. So this is someone who's had scaffolds. So these are these bioabsorbable stents that they used to put in. They weren't a great success, as you can see. In 2022, the image on the left, it's not a bad image. That's using first, and the image on the right is peak 1024, and it's just everything is just much better seen, and you can actually see the stenoses there in a way that we couldn't have done before. So this is comparison with 2015 to the present day. The image on the left is an old Aquilion 1, and then the image on the far right is with every bell and whistle with peak 1024. And the resolution increase is huge as you go through the different reconstruction systems. And it's now got virtually no noise and very high resolution. And this is a big patient, BMI 33. The dose is very reasonable. Just that to get the absolute best resolution, what we don't want to do is scan the patient at a DLP of like 10, because we won't get the best resolution out of the system. So this is able to scan at low dose and get fantastic resolution. But this is kind of everyday patient. They're going to go for an aortic valve replacement. We want to look at their valve. They want to measure them up for TAVI. And in the old days, we didn't look at their coronaries really, but now we can look at their coronaries, even when they got loads of calcium. This is someone with loads of calcium in the coronaries, but they haven't got any flow-limiting disease. So we have saved them a cardiac cath because we got better resolution, and also because the images are still, because we can't beta block these patients. So we're able to cope with that because we got a 0.24 rotation. And we've started to do stuff, for better or worse, that we didn't do before because we got much better temporal resolution. We're very good at endocarditis now. We're able to, even if they got metal, and this shows big vegetation on the aortic valve. So we're able to see stuff that we couldn't before because the resolution is 120 milliseconds. So this system overall copes much better with metal in general, but particularly metal in the heart. This is someone with a stent. This is not an easy patient. This is not the best one I've ever shown. This is just a typical one. Atrial fibrillation, 70 beats a minute, peak 1024. And you can see that stent is very, very well seen, and the proximal calcium is well seen. And you can see there's a dark bit within that distal stent, which is occlusion of that stent. And you can even see the individual struts, and we wouldn't have got anywhere close to that before. This is just to show the difference between hybrid iterative reconstruction against peak. Hybrid iterative reconstruction is the one that served us well for many years. It's the ones that most of the vendors use. And that's one of those images, quite a nice image of two stents. Keep your eye on that proximal stent there, and then that's peak. So I couldn't have cleared that stent before, and I can now. We've got much better resolution. So this is CMAR, which is single energy metal artifact reduction, which Canon has had a while, but this is particularly powerful when you put it with peak 1024. That's an image on the left with no CMAR and peak 1024, and there's still quite a lot of streak artifact from that ICD, and then with the CMAR on, there's no streak artifact as well. But the combination of the peak and the CMAR is unexpectedly powerful. It really takes out all the artifact from the metal completely. And this is another image showing a metallic aortic valve replacement. And we get so little artifact now that we can see there's actually a hole next to that. There was aortic regurg after a aortic valve replacement. And that's a high heart rate, end diastolic recon, and you can see that hole. And they use this to plan information. So we're doing to plan intervention rather. So we're using a lot of this now with metallic valves. It seems to be much better than transesophageal echo. This is if you can't ECG gate the patient because they're thrashing around, they're in the emergency room. You don't actually need to for things like dissection anymore. We can ramp it up right to the 0.24 second rotation, and it's got a very fast table speed now, much faster than it was before, more than double the table speed we had before. So we can blast through the whole neck and chest in about less than 1.5 seconds, and it freezes the aortic motion with no ECG gating. Now we don't routinely do this at the moment because I'm trying to convince my colleagues that we need to change is difficult. But this is not for the coronaries, but it gives you very still aorta and it's good enough for dissection. So there's something called silver beam. It's silver wedge filtration. You'll hear about that a bit from Patrick later. Basically, it's the same technology we use for the scanogram. We can also use it diagnostically. We filter out almost all of the low energy photons, leaving you with the high energy photons only. And with that, if you're not given any contrast, any IV contrast, you can get very high resolution, low dose images of the chest. And that's a beautiful image of lung fibrosis there with ACE, with the DLP of 38. So that's using deep learning. This is we've sort of learned surprisingly that the new Peak 1024 lung gives you a lot more resolution than the old state-of-the-art ACE recon did. The image on the left with ACE and the image on the right with Peak 1024, and if I zoom it up, you can see detail in that lung that you couldn't see before. On the left, we thought that was ground glass change. This is someone 4 months post-COVID. On the right, they've got established lung fibrosis. And do I know that's true? Probably is, because that's what the pathologists say happens. And so I think we're showing us the truth. You have to slightly relearn what you're looking at with the ultra-high resolution lung images. The image on the left is a non-smoker. It's normal, but you can see things like secondary lobules that we never saw before. That is normal. The image on the right is a smoker, and most smokers seem to look like this, even without lots of emphysema. They have this sort of diffuse reticulation from fibrosis. And again, the pathologists say that this is very common in smokers. We just didn't see it before. So what about the rest of the body? Using a combination of CMAR and the ACE, we can see periprosthetic fractures very well. It suppresses the artifact. This is a cervical spine using ACE and silver beam. So it uses it's very high energy photons, so there's very little, if any, beam hardening. And then we put ACE, the deep learning reconstruction, on top. And the image on the left looks like a cadaver's image in front of you. It looks like the one I used to have. In fact, it's the one I've got on the top of my wardrobe, but there's a skeleton. And that's and there's no artifact at all around the shoulders at all. So I think, I'm not an MSK radiologist, but even I find these images much easier as a cardiac radiologist to interpret than I would if they were all streaky like they used to be. This is body image using ACE, DLP of 308, so low dose, really good low contrast resolution. You can see that enhancing metastasis. This is 0.5 millimeter slice thickness. If you've got a good image with Peak 1024, makes your ACE image even better. This is the vision on the left, ADA 3D, the insight with ACE in the middle, and the insight with Peak 1024, and it just keeps getting better. And this is someone with BMI of 59. You can even scan at 0.5 and reconstruct at 0.5 with them, and you get lovely images with minimal noise and no artifacts. And this is, BMI 59 is quite large. And this is zoomed up just to prove I'm not cheating. This is the BMI of 59.5 millimeter Peak 1024. There's nothing I can't see on that image, and they're a very large patient. So I've shown you some clinical images. I've talked a bit about workflow. And I think that, in summary, the automated scanning with the Instincts interface is our friend. It is disruptive, but it will help us cope with the huge demand with radiographer shortages. And it is not going to make anyone redundant. I think it will make people, our experience is the radiographers love it, even the ones who said they were going to hate it. And actually, it's freed us up for them to do other other roles. Some of them they do lots of things, extra little bits and pieces that they didn't have time for before, and it's able to fill the jobs that we couldn't, to fill the roles essentially that we couldn't fill before. So I don't think it's a threat. It gives us a helping hand, instincts, guiding the technology through the scanning process. If you're in a stressful environment, it really helps. And it takes a great platform, the insight, I think, and makes it better. It's not just incremental, it's quite a lot better. And we get great images, and we haven't had a radiation dose penalty. So I'm happy we can get rapid, consistent, great images in almost all patients, in lots of patients that we couldn't see before, and it doesn't matter what their heart rate, rhythm, or size is. So I thank you for your time.